Second lecture for this week's material within endocrine therapy is the pharmacotherapy of osteoporosis. So again, take a look at the guidelines as well as the objectives that are listed in black. We'll be taking a look at the medications, both non-prescription and prescription, that are used to treat osteoporosis, as well as the dosing, monitoring, adverse effects, and other clinical pearls. I'm assuming and hoping and expecting that you have looked through the textbook as well as those the National Osteoporosis Foundation guidelines and the AACE guidelines for osteoporosis to understand the definition of osteoporosis and how we diagnose it, as well as the risk factors. What we'll be talking about again is how do we treat it. So our big goal with looking at the outcomes is really trying to prevent the problems associated with osteoporosis, worsening bone mineral density, fractures, future fractures that may occur, and also looking at the secondary causes of osteoporosis and trying to minimize those, whether it's from medications or diseases. We're also looking to help those patients improve their bone mass and their strengths and stabilize it, because that will lead to less fractures as well. First part to a bone healthy lifestyle and to preventing or treating osteoporosis is taking care of the body. Quitting smoking, since smoking will leach calcium out of the bones. Exercise to strengthen those bones, both weight bearing and resistance. Fall prevention, so whether that's working on the core to help keep people to have good balance, as well as going into the home or talking to the patients about making sure they don't have slippery floors or carpets that can come up and that they can trip over, that they are able to get in and out of their bed or out of the bathroom easily and have guardrails or things that they need. And then looking at a healthy diet that includes enough calcium and vitamin D. From our diet, we do need the calcium. We get that. We get vitamin D both from our food as well as the sun. Caffeine and alcohol all can be somewhat negative for the bone, so we want to avoid excess, alcohol especially. Vitamin K, it's been controversial in whether a deficit in vitamin K contributes to osteoporosis. So you'll see some calcium pills, mainly the Viactive Chews, had the vitamin K added in. So some of these other things, it's controversial. This is from the federal government with what the recommended daily allowances are, so it's real important to keep in mind what's needed for patients in the different age groups. You can see that women, once they're age 50 and above, they need a higher dose of calcium, 1,200 milligrams, whereas men don't need the higher dose until they're age 70. Men certainly are at risk for osteoporosis, but it happens much later, usually in their 70s and 80s. Vitamin D, same. In this category, men and women are treated the same. Men and women age 51 to 70 need 600 international units, and men and women over the age of 70 need 800 international units. You will see certainly patients that are taking more. The National Osteoporosis Foundation does recommend a higher dose of 800 to 1,000 units daily. That has been generating some controversy just recently, and I'll share that with you in some of the research that's been done on whether vitamin D is helpful in preventing fractures. For calcium, we really want to encourage intake to get to that 1,000 milligrams or 1,200 milligrams from their food or beverages. We know that having enough calcium can help delay bone mineral loss, especially in postmenopausal women, and it can reduce hip fractures by a large percentage. In patients who don't have osteoporosis, again, we want to use supplements if we can't get there from their dietary intake to get to the targets. Sometimes in patients who already have osteoporosis, you may see providers who you may want to increase that dose up. We really don't go much more than 1,500 milligrams of calcium in a day. But you can use calcium carbonate, calcium citrate, or the tricalcium phosphate. They're very similar. There's some differences between them, and it really depends on price, patient preference, and adverse effects. You don't want to give more than 600 milligrams in one dose. The stomach, the body can't absorb more than 500 to 600 milligrams at a time. So if the patient needs to get 1,000 milligrams in supplements, they need to separate that into 2 doses. Adverse effects from calcium in general, it binds people up. So it's constipation, some gas, upset stomach, can cause kidney stones, especially at the higher doses, so we want to avoid that. There are interactions. Proton pump inhibitors will interact with calcium carbonate. We have to be careful with iron, tetracycline, quinolones, bisphosphonates, phenytoin, fluoride, levothyroxine, I didn't put that on there, that as well, because that can bind with the calcium, fiber laxatives and thiazides as well. So calcium carbonate, that's the most common. It's the least expensive. It's what's in Tums and some of the other products. It does need to be taken with food because it requires stomach acid to be absorbed. It can cause a lot of GI upset or this constipation with it. But again, you'll see that the most often because it's the least expensive. Calcium citrate is very good for our elderly patients or patients that are on proton pump inhibitors or H2 blockers. It doesn't require stomach acid to get absorbed. So if somebody is not taking it with food, our elderly patients already don't have enough stomach acid, and patients who are on proton pump inhibitors don't have enough stomach acid, then this is a better option for them. And then the tricalcium phosphate is mainly used to fortify different foods with calcium. Vitamin D, it's found in fish oils and fortified foods there. We also produce it in our skin when we're exposed to sunlight. It helps to maximize the absorption of calcium from the intestines. It has been shown in some patients to decrease fractures, falls, so it is an important supplement in patients who have osteoporosis or in who are trying to prevent it. There is some controversy in whether the appropriate level is 20 nanograms per milliliter or 30. Some of the lab data will show you 30, 32 nanograms per milliliter, but there are others that will say in some of the studies that have been done that it's the 20, that it's okay, that we shouldn't be treating vitamin D levels unless they go below 20. Again, I'll remind you about what the appropriate doses are. According to the RDA, it was 600 to 800, depending on the age of the patient. National Osteoporosis Foundation goes a little bit higher, and most recently, the American Association of Clinical Endocrinologists goes even higher still, 1,000 to 2,000 units every day. So when do we treat? Again, as we have the DEXA scan being done, we look at what the T-score is, and if the T-score is above -1, higher than -1, so 0, +1, +0.5, even -0.5, that's better than -1, that's considered normal and no treatment's needed. If they're between that -1 to -2.4, it's considered osteopenia. And we typically may use a preventive dose of bisphosphonate, or if we've done the FRAX risk assessment, if they have a 10-year fracture risk, more than 3% for hip or more than 20% for any major osteoporotic fracture, then you may also treat with the prescription therapy. If somebody a woman has a T-score below -2.5, that's considered osteoporosis, or if they've had a low trauma fracture, even with a higher bone mineral density like a -1.5, that would still constitute needing treatment. So when we do treat, we're going to talk through the therapies. Bisphosphonates are our first-line therapy. Raloxifene, denosumab, teriparatide, and then intranasal calcitonin we'll touch on. Bisphosphonates are really the first-line therapy for both men and women. Decrease bone resorption by inhibiting our osteoclasts from acting and reabsorbing the bone. They have very long half-lives, which can lead to some difficulties or drug holidays, as we'll talk about. Very low oral bioavailability of only 1 to 5%. So that's going to mean that the patient really needs to be educated about how to take the medicine. All the bisphosphonates reduce vertebral fractures by at least 40%, and they all improve the lumbar spine or femoral neck bone mineral density. All of them can be used for both the prevention or treatment of osteoporosis, and all but abandronate, which is Boniva, all but abandronate reduce both non-vertebral fractures and hip fractures by a significant amount. There are adverse effects with oral bisphosphonates. They are considerable and things to consider. They can cause nausea, vomiting, or diarrhea, but the bigger issue is some of the dyspepsia and abdominal pain that patients will get. It's a large enough pill, and they really patients can have esophageal irritation if the pill gets stuck on its way down or is not taken with enough water. And so there's been GI bleeding and perfs and ulcerations that have developed. So it's real important that patients take it correctly, which we'll be talking about. There are some drug interactions, mainly with calcium and vitamins, just with absorption. And since it has a very low bioavailability to begin with, if patients take it with calcium, that's going to pretty much negate its effect. There are, with the intravenous bisphosphonates, just some local injection site reactions, maybe a little flu-like or fever symptoms. Some of the more important warnings with bisphosphonates are the atypical fractures. There's been some subtrochanteric and femoral shaft injuries, and it's been either just a spontaneous fracture or after minimal trauma. So we're not really sure why, but the thought process is that it's a frozen bone, that there's either low bone turnover or bone oversuppression, and then the bone doesn't have a chance to regenerate and get stronger. It increases with the length of therapy, and it does tend to decrease once the bisphosphonate is discontinued. So you may have one atypical fracture for every 100 hip fractures prevented. Still worth it to use, but just something to consider. Osteonecrosis of the jaw has certainly generated a lot of interest. It's much more common with the high-dose intravenous bisphosphonates, which is those used in cancer therapy, as well as if somebody's been taking the bisphosphonate for over 2 years. What happens is that you see the osteonecrosis of the jaw after somebody's had mouth trauma or surgery in the mouth or a tooth extraction, so there's been some trauma there. Like we said, the chemotherapy tends to have be a risk factor, as well as also being on steroids, having dental problems, having radiation treatment, or having an infection. The risk with oral alendronate, which is your first-line agent, it's very low, but it's still something to be cautious about. Again, oversuppression of bone turnover, so you have weaker bone developing. What you have to do is you may have to do surgical debridement, but typically you give antibiotics, the chlorhexidine washes, and then pain medication, analgesics. So with the bisphosphonates, we don't want to use it in patients who have a lot of esophageal issues, maybe once they're taking the oral dosage form, or have a very strong history of esophageal irritation or ulcer, or very low calcium hypocalcemia. There are lots of different doses. There's a low daily dose, there's a weekly dose, monthly dose. There is a liquid formulation available of alendronate. There's IV doses that are given either once a year in the case of zoledronic acid or every 3 months in the case of abandonate. So there's a lot of options for patients. The most common is the weekly dose of the alendronate or risedronate. You do need to avoid using these agents when patients' renal function is severely severe. If it's less than 35 milliliters per minute for alendronate and zoledronic acid, and then 30 for abandonate or risedronate. I did list the dosing here for your more common ones. Alendronate, again, most common, abandonate, risedronate, and then zoledronic acid is only used IV, and that's once a year. Here's where the patient education comes in to help avoid those side effects and help with the bioavailability. Patients need to take it with 6 to 8 ounces of water so that it really does get totally pushed down into the stomach and not cause the esophageal irritation. And they need to be sitting or standing. They can't be laying down. And they need to sit or stand and take it 30 minutes before having any food, medication, or other drink. It's 60 minutes for abandonate. I just tell every patient 60 minutes. I find that a lot of patients will do half of what you tell them. So if you tell them 60 minutes, they'll do 30 minutes. So they need to take it with a big glass of water, not lie down for 30 minutes after taking it, and not eat, drink, or take any medicine for at least 30 minutes, really, 60 minutes preferred. So that can be difficult. Luckily, if you give it once a week or even once a month, that's not quite so bad. But it means if they get up early to take it, they can't go lay back down to bed because they can't be laying down. Or they can't go and have their cup of coffee. They could go shower, they could go take a walk, they could do some of those other things. The liquid formulation, if somebody's having trouble swallowing, it does only require a couple ounces of water, but somebody still has to be able to swallow water. So again, when you're talking with your patient, talk about what would work best for them. For some people, they can't remember to take it once a week, so maybe daily is better, or monthly is better, or doing the infusion once a year. As we talk about drug holiday, I found this good chart for us to discuss. This is nice. It's out of the AACE guidelines, out of a newsletter from the NOF, and it helps you kind of stratify the risk for fracture. So the higher the risk for fracture for the patient, the longer you want to treat with your bisphosphonate. And then there's some suggestions. There's nothing that's got in the package insert or anything like that. This is all just suggestions. So for instance, if you have somebody at very high risk for a fracture, you need to treat them with the bisphosphonate for perhaps 10 years, then stop for a couple years and watch to see when their T-score decreases. If they have a fracture, you could use another medication instead, that sort of thing. And for your milder patients at a much lower risk for fracture, well, then you may want to treat for just 3 years or up to 5 years, and then stop for several years and see how the patient does. So those are some options to help guide you in your therapy and when to discontinue treatment. These medications, like I said, have a very long half-life, which is why we can probably do this drug holiday for several years, because there's still so much left in the body. Moving on, we'll talk about raloxifene, and that's a second-line medication, even probably considered third-line in some cases, just for women only. It's a selective estrogen receptor modulator, a SERM, and it works as a positive estrogen agonist on bones, which helps protect bones, but it works as an antagonist on breast and uterus, which is how it also can be used to help prevent breast cancer. It's related to tamoxifen and terimethine. It decreases bone resorption and bone turnover. It works well. It can reduce vertebral fractures and helps improve bone mineral density, but not as well as the bisphosphonates. And unlike most of the bisphosphonates, it doesn't reduce hip fractures or non-vertebral fractures. The adverse effects, if you can remember, like with tamoxifen, what we're worried about, it's some of those same things: hot flashes, leg cramps, peripheral edema. We worry, though, more about the venous thromboembolism and potential fatal stroke that could develop. So it's certainly not indicated for patients who have had a previous venous thromboembolism or PE, or somebody who has one currently, and then contraindicated in pregnancy as well. But again, usually you're only treating osteoporosis in postmenopausal women. The dose, it's an oral tablet, 60 milligrams by mouth once daily, and it is available generically at this point, so cost should not be quite an issue. Same with bisphosphonates. Those have been available for many years, so they're available as a generic medication as well. Moving on to denosumab, which is not available generically because it's relatively new. It's a second-line therapy, but certainly some providers are using it first line. It's a monoclonal antibody against rankle, which is rankle is what's transmitted. It's a ligand that helps inhibit the rankle gets the osteoclast moving, and this is an antibody that works against rankle, and it inhibits the osteoclast activity and decreases bone resorption. So it works well in that activity. It is very similar to the bisphosphonates, and you'll see the side effects are very similar, so it has very similar benefits used for the treatment of osteoporosis. So some of the adverse effects are going to be the same: nausea, vomiting, diarrhea, hypocalcemia. The same thing with the renal dysfunction. Avoid if patients have a low creatinine clearance. But there's some other, and the osteonecrosis of the jaw, that's similar to the bisphosphonates. But there's a few different things. The infections, there's cellulitis that has occurred, some other skin reactions. Could increase the cholesterol, but not typically anything alarming, and some pancreatitis that could be an issue. Again, with this one specifically, it is contraindicated in patients who have hypocalcemia. It can really cause a low calcium, so patients do need to take calcium and vitamin D during therapy. It's a subcutaneous dose, and it's done through a doctor's office. It's 60 milligrams sub-Q every 6 months. It needs to be refrigerated. It's less than teriparatide, which is what we'll talk about next. So it's about $900 for that one dose, so about $1,800 for the year. Again, much more expensive than your bisphosphonates, but it's twice a year dose. Patients may prefer that if they have a lot of esophageal problems. It comes as, it's also marketed as a different brand name for the treatment of bone metastases. So it's Prolia for osteoporosis, but it's Xgeva for the treatment of bone metastases. So just be aware of that. There is a REMS program for it to watch for the hypocalcemia. The parathyroid analogs are a newer class of medications used to help treat osteoporosis. They're known as recombinant human parathyroid hormone analogs, and their place in therapy is for patients who have a very high or severe fracture risk. They have severe osteoporosis, have failed bisphosphonates, or can't tolerate bisphosphonates or any of the other agents. They work very well, and so in patients who do have severe osteoporosis with a T-score less than the negative 3.5, they could be used as first line, but typically they are not, only because of their cost, and they are an injection, a daily injection. So they work very well, but we don't see them as first line, at least not yet. They do increase bone formation and osteoblast number and activity. That's how they work. And again, it works better than raloxifene, so it would be preferred over raloxifene in patients who've had a low trauma fracture. They work very well, as I said. They reduce vertebral fractures by up to 86%, non-vertebral fractures by up to 50%. They do improve bone mineral density in the lumbar spine and the femoral neck. They don't have as much of an effect on patients who have hip fractures or very low bone density there, and it's not to be used for prevention of osteoporosis, only treatment. The adverse effects that we as clinicians and providers need to watch out for is hypercalcemia, nausea, headache, leg cramps, can cause orthostatic hypotension and dizziness. So when patients are first starting the therapy, it is best if they're laying down or reclining, so that after they give themselves the first injection, or any injection really, on a daily basis, that they're seated or laying down, so as to avoid any problems with a fall or having dizziness. There are injection site reactions, just because it is a subcutaneous injection. Shouldn't be used in women who are premenopausal, as most of these should not be. There is a black box warning for osteosarcoma. It's more likely to occur in patients who have Paget's, alkaline phosphatase elevations, pediatric patients, which it's really not approved for, patients who've experienced radiation therapy, and again, children or young adults, that we typically wouldn't use this agent in any way for postmenopausal osteoporosis. Right now, there are 2 parathyroid analogs. One is abaloparatide. It is 80 microgram subcutaneous injection once a day. It comes in a pen that must be refrigerated and with 30 doses. And again, patients should sit or lay down during and after the injection. Teriparatide was released first, and that is a dose of 20 micrograms every day subcutaneously. Again, both of these are more expensive than the other agents we've talked about $2,000 per month. So sometimes insurers will require a prior authorization in order for you to prescribe it, for the patient to receive it on their insurance, meaning they have failed bisphosphonate or have very severe osteoporosis. Both of these agents have been only studied for up to 2 years of treatment, and then must be switched off to something else, and typically that would mean going to a bisphosphonate after those 2 years of therapy. Intranasal calcitonin, not really used much anymore. It's 3rd line, 4th line, maybe even 5th line. Salmon-derived, it helps to inhibit bone resorption because calcium is released from the thyroid gland when calcium is elevated, so it's telling the body to quit breaking down bone. We got enough calcium, quit breaking down bone. It's similar to relaxifene in how well it works to reduce vertebral fractures. Doesn't help non-vertebral or hip fracture risk. It's a nasal spray, so it's 200 units intranasally daily. So Monday, it's left nair, Tuesday, right nair, and then back and forth. So most of the side effects have to do with that, the rhinitis and nasal dryness and irritation. Where we see it used is if somebody's had a vertebral fracture. It seems to have some analgesic effects in women who've had some back pain when they've had a fracture, so it may be useful there. Previously, we would use estrogen, not only to treat menopausal symptoms, but also to help with osteoporosis. We don't do that anymore, and so you may see estrogen used to help menopausal symptoms, a low dose, but we don't want to use it to treat osteoporosis. Testosterone can be helpful if patients have hypogonadal symptoms, like men have hypogonadal symptoms as they age. It may help them reduce bone loss. Thiazide diuretics will increase calcium, and so there can be small increases in bone mass, but it's not going to help treat a low T-score. So as we kind of review, first line, especially for that hip and spine, and the hip is so important, we use alendronate, risedronate, zoledronic acid, those bisphosphonates. Denosumab you could utilize in a woman. Some providers, again, like I said, are using it because it's similar to the bisphosphonate. A little more expensive, obviously. Second line therapy for spine fracture prevention, maybe abandonate and raloxifene. Third line, raloxifene. Fourth line, calcitonin. And then again, if you fail a bisphosphonate or have a very high fracture risk, very low T-score, teriparatide. If we think about children, we don't worry about osteoporosis so much for them, but in patients that have hypercalcemia, you may use pamidronate. Premenopausal women, we typically don't do bone mineral density testing, and there's no evidence for the most part that we treat them with medications. We certainly want to talk with women and men about getting enough calcium and vitamin D. I think men sometimes are forgotten that they too can get osteoporosis. It does tend to happen at an older age than women. Women at menopause and beyond, so 45 on up or 50 on up. Men, usually it's age 70 or over. So that's when we start testing them and also order those testosterone levels. Their treatment's very similar, as we discussed. You want to start with fall prevention and the bone healthy lifestyle, making sure they have enough calcium and vitamin D. Again, the bisphosphonates are first-line therapy, and you could use the teriparatide if needed for severe osteoporosis. Patients who are taking glucocorticoids systemically, orally primarily, are at a much increased risk for osteoporosis. Glucocorticoids increase bone resorption and inhibit bone formation, so patients are at very high risk for fractures. 30 to 50% of patients taking glucocorticoids will have a fracture. The greatest bone loss is actually in that first 6 to 12 months of therapy, so it is very important to be thinking about the risk of osteoporosis as you're starting long-term, or what you think may be long-term, glucocorticoid therapy. It is recommended that bone mineral density testing is done and treatment optimized for patients if they're going to be taking prednisone 2.5 milligrams or more daily, or another steroid, but that equivalent dosage of prednisone 2.5 milligrams daily for at least 3 months. So if somebody's just getting a week's worth or even 2 weeks worth, maybe even up to a month for treating respiratory infection, that's not considered long-term. It's 3 months or longer. There were recent American College of Rheumatology guidelines that have updated their recommendations on how to treat patients who are taking long-term glucocorticoids, since a lot of patients with rheumatoid arthritis do take that. Smoking cessation is important, limiting alcohol to only 1 or 2 drinks per day, optimizing calcium and vitamin D, 1,000 to 1,200 milligrams of calcium per day, 600 to 800 international units of vitamin D per day. And as with the standard treatment for osteoporosis, bisphosphonates are preferred. Oral first. If somebody cannot tolerate oral or has issues or doesn't seem to be having results, then you can move on to the IV bisphosphonates, teriparatide or abaloparatide, and denosumab, and then raloxifene would be further down the line after you exhaust the use of the bisphosphonates. Monitoring, typically you're going to do DEXA scans, so looking for T-score changes. DEXAs should be repeated every 1 to 2 years. You want to see stable T-score or a better T-score happening, and then also looking for patients to be taking their calcium and vitamin D, being adherent to their medication, looking for a decrease in fractures or not, especially if they've had one previously. And then again, as we talked about, looking at drug holiday for the bisphosphonates, and looking at sequential therapy if we need to, if patients are having adverse effects or whatnot. So that's our review of osteoporosis medications. If there are questions that you have, please don't hesitate to contact me. Want to help you succeed in the upcoming quiz and on the final exam.